So what else is out there? What other proposals are out there? Patient Freedom Act, proposed January 23rd, 2017 by Senators Cassidy and Collins from Louisiana and Maine. What would it do? This is kind of the middle ground approach in terms of how the Republicans could proceed. It would repeal the individual mandate, get rid of the pay-or-play rules, the ESR, employer shared responsibility rules. And then it would allow states to kind of pick and choose how they want to handle health care reform. So, for example, if a state wanted to keep the Affordable Care Act, if California or New York or Massachusetts, some of the more liberal states want to keep the ACA, they could keep it. They wouldn't receive the exact same funding from the federal government in terms of the exchanges. It may be lesser, but the basic concept is, you know, if you're in that state, you would have an ACA exchange available to you in that state, again, with possibly limited subsidies. Then the next one is kind of a default rule where if the state doesn't choose, they go into something called a market-based alternative. Market-based alternative details are a little bit vague. It talks about a skinny down high deductible health plan. So some kind of high deductible health plan with federal money going into your own HSA. So if, you know, Wisconsin, to use an example, let's suppose that we're kind of a middle ground purple sort of state. We can't decide what to do, so we say, let's just go with kind of the default here. Individuals in Wisconsin would have some kind of subsidy to buy health insurance, go into an HSA. The HSA funds from the federal government could be used to buy an individual policy. Then finally, you have the go-it-alone states, the states that say, we just don't want to provide any assistance to our citizens, to our residents. We're just abandoning this entirely. So they would decline the offer of free federal money for their residents at that point. And that bill, by the way, it is kind of a middle ground, and so it's kind of suffering from the mushy middle type of approach. House leadership is not in favor of this. House leadership is strongly saying that the AHCA, the American Health Care Act, is the only way forward. So they're kind of rejecting that idea out of hand. So in terms of where the AHCA came from, primarily from this. Paul Ryan, Speaker of the House, of course, from Wisconsin, has previously laid out a Better Way healthcare reform, June 2016, 37-page document, lays out kind of the basis for how he thinks healthcare reform should be changed here. First of all, repealing the ACA. And again, these are sort of talking points. It's not legislative text, so you know, legislative text is hundreds of pages long. This is more talking points. Repealing the ACA. Not clear, though, under Speaker Ryan's bill if some of these things would change or would be kept. For example, keeping kids until age 26. You know, President Trump, of course, ran on that as part of his platform, said he absolutely wants to keep that age 26. So again, that's one of the details which isn't addressed in Paul Ryan's ideas here. Expanding HSAs. Again, Republicans love HSAs. Increasing contribution limits, catch-up contributions for spouses. Expanding HRAs, health reimbursement arrangements, where they can reimburse individual insurance premiums. Right now, if you sponsor an HRA, you probably don't allow employees to go out and buy their own individual policies. That creates some HIPAA non-discrimination issues and other kind of concerns, legal concerns. So, you know, fuddy-duddy lawyers like me tell you not to do that. But this would kind of flip that rule and say, don't listen to the old lawyers here. You can ignore them. You can go ahead with this. So now, interestingly, that idea actually recently became law. It was kind of stuck into the 21st Century Cures Act, which we'll talk about later, at least with regard to small employers. Those who have less than 50 full-time employees, they can have these QSARAs, Qualified Small Employer HRAs. The QSARAs can actually be used to buy individual policies from the employees. The next concept that Republicans have to wrestle with here is dealing with adverse selection. Adverse selection is the concept that if you go without health insurance, but then rush down to buy health insurance once you get sick, the insurers take a beating, right? If I know that I've got a knee replacement that I need to have in 6 months, I wait 5.5 months, then I go out and buy health insurance. I get my knee replacement covered for 1 month, and then I stop paying. Insurers get killed. So ACA kind of deals with that through the individual mandate. We also have kind of continuous coverage. Republicans don't like the individual mandate. They replace it with a continuous coverage rule Paul Ryan doesn't have a number associated with it, but what he says is that if you have a gap in coverage, then when you go back to apply for coverage, again, I need knee surgery, I run down to buy coverage, the insurer can charge me more. Maybe it's 30% more, maybe it's 50% more, maybe it's 100% more. But again, the insurer should have some ability to charge me more to deal with the adverse selection risk. Also, the Ryan outline would cap the employee exclusion for employer-sponsored coverage. This is sort of a replacement of the Cadillac tax. The idea being that if you look at how much health plan coverage costs and how it's not taxed to your employees, that's the largest tax expenditure in the Internal Revenue Code, about $260 billion a year. Congress looks at this and says, $260 billion is a lot. It would be nice if somebody paid some taxes on that. Maybe we shouldn't be quite so generous. And so again, the idea is let's cap the value of that coverage. Under a draft of AHCA, it would have capped it at about the 90th percentile level. So if you were in the top 10% in terms of being most generous, it would actually tax you on the value of that coverage. Paul Ryan plan didn't include a number here, and the final version of AHCA dropped that 90% rule, but you can kind of see where Republicans are leaning in that idea. Healthcare backpack, universal advanceable refundable tax credits with no Medicare, no Medicaid, no employer offer. Again, the idea that people should have some assistance in terms of buying health plans here. Note 2, from an employer perspective, the last point on no employer offer. What this means from an employer perspective is that there's going to be some tracking of offers of coverage, right? Just like right now you have to track offers, you have to track who accepted, who's in the plan, et cetera. Under this Republican idea and under AHCA, as we'll see later, you do have to track offers of coverage or whether people are actually eligible. So, the 1094 forms, the 1095 forms may be going away as forms, but there's still going to be some kind of employer reporting, which is likely to be required in the future. Less detailed, maybe it's just who's eligible, who's offered, maybe not the whole ACA full-time concept, but this offer idea will be out there. All right, Empowering Patients First Act, introduced multiple times by Representative Tom Price, Republican of Georgia, now HHS Secretary. Similar to Speaker Ryan's plan, so we're just going to hit the highlights here again. Repeal the ACA, provide assistance to buy individual policies, which increase with age, but without any income cap. So, the Warren Buffetts, the Bill Gateses would get federal assistance to buy health insurance policies. Expand HSAs, cap the employee exclusion for employer-provided coverage, repeal Medicaid, deal with adverse selection through continuous coverage, again, same as the Paul Ryan, allow sale of insurance across state lines, again, the Donald Trump idea out there too. Patient Care Act, this is the one from the Senate, that's kind of the leading Senate one, which is out there. The other ones have been House-related. This is a 2015 sort of an outline of a bill, again, more speaking points. There's no legislative text from some leading senators on the Republican side. Very similar concepts. Again, repeal the ACA, prohibit lifetime limits but not annual limits, allow that 3-to-1 ratio for insurers to move up to 5-to-1, then let the states handle it. Kids covered until age 26, adverse selection through HIPAA-like continuous coverage rules. And again, targeted tax credits for employees at small businesses or for large companies where the employer has no offer of coverage. Again, offers of coverage, employers would have to track that. And again, age-adjusted advanceable refundable tax credits. The one interesting thing here is at the bottom, the last bullet point, we finally get a number associated with the tax here. Cap employee income exclusion, $12,000 for individuals, $30,000 for families. So again, if the value of your coverage for an individual was $14,000, the individual would pay taxes on the difference between $14,000 and $12,000. So they pay income taxes on the $2,000 difference, which of course would inspire, I think, a lot of employers to try to keep the value of their coverage below those limits so that your employees wouldn't be hit with those taxes. All right, the goals, state goals of President Trump. He used to have a web page. I think it's gone. I can't find it anymore. But he used to have a Healthcare to Make America Great Again web page which talks about different ideas, very similar to what we've seen. Again, repeal the ACA, sale of insurance across state lines. Individuals can fully deduct their health insurance premiums, expanding use of HSAs, provider price transparency. Again, very helpful if you have HSAs. Block grants to Medicaid states, allow importation of prescription drugs. He's also stated in different contexts that he wants to have insurance for everybody. They sort of are liberal in this area. He wants much lower deductibles, and he says he's not going to cut Medicare or Medicaid, even though other Republicans want to. So, all right, where does that leave us? Well, it leaves us with sort of a three-step process that Republicans are going to be following here. The first one that we're in right now is in phase one, where they use the reconciliation process to pass some changes to the Affordable Care Act. Why the reconciliation process? You may recall that when the ACA got passed, sort of an interesting process. They were, at the time, after Obama kind of swept into office, Democrats had 60 votes in the Senate, they had a majority in the House, so sort of had control over everything. Went ahead and passed a bill in the House and passed a bill in the Senate, and then Senator Kennedy from Massachusetts died. And somewhat shockingly, Massachusetts elected a Republican instead of a Democrat, which meant that suddenly Democrats only had 59 senators, not 60. Therefore, the Republicans could filibuster any kind of bill. So in order to finalize health care, they had to go back to the House version and sort of pass that through a special reconciliation process with, again, only 59 votes, not 60 votes in the Senate. And so that means that when you're trying to undo the Affordable Care Act, because they didn't have 60 votes at the time, Republicans now don't need 60 votes to kind of undo it. Everything can be done, or some of this can be done through reconciliation. So the things which can be done through reconciliation are what they're focused on right now. Republicans, of course, don't have 60 votes in the Senate. They only have 52 votes, and they're not anticipating that any of the Democratic senators will vote in favor of whatever they put out there. So anticipating Democrats are going to vote against everything. So they say, okay, let's try to figure out what we can repeal through this reconciliation process. And the rule here is that they can only change things which lower the deficit over a 10-year time period by at least $2 billion. So again, there has to be kind of a deficit reduction process, really limits the changes which can be made. And so, for example, that's why they can't technically take away the pay-or-play rule. They can just drop the penalty down to 0. Because to actually take it away, they probably need 60 votes. Tax cuts here are going to lead to further tax cuts later in the year when they start doing tax reform too. So again, we're in kind of phase one of the process. Phase two of the process, HHS Secretary Price, the Secretary of the IRS, Secretary of Labor, et cetera, are going to make some changes to the underlying ACA regulation. We don't know exactly what those changes are going to be. They've just talked about changing things, modifying things. One of the things I think they're likely to take away is probably contraceptive coverage. Right now, if you have a non-grandfathered health plan, you have to provide contraceptives on a first dollar basis. That has sort of been targeted by HHS Secretary Price. So again, there will be some changes. There will be some changes around kind of the margins in terms of cutting back on some of these benefits which are out there. Again, to the extent they can do that through applicable law. Phase three. Phase three would be later in the year. Phase one, they want to complete by April 7th before Congress goes on their Easter break. There's been some pushback in the Senate. Some of the senators, including Republican senators, have said don't stick to an artificial April 7th deadline. Don't worry about getting it done before Easter. You know, we'll deal with it later in the year. The House leadership says no, April 7th, we want this done by the time we leave here to go back. The price piece, the phase two piece, when would that be? Probably over the next year or so, right? It's kind of a formal rulemaking process to unwind these regulations. So that will be going on kind of in parallel with phase one. Phase three is using the legislative process for non-reconciliation items. So phase three is doing the things that they can't do through reconciliation. For example, selling insurance across state lines has no real impact on the budgetary numbers. So again, if we want all the insurance companies to be based in Utah, we're going to need sign-off from the Democrats in the Senate, as long as they have at least 48 members in the Senate. We're going to need some kind of approval there through that process. Or importation of prescription drugs. If we want to allow for importation of Canadian prescription drugs or Mexican prescription drugs or whatever it is, again, it's going to require bipartisan agreement in the Senate, and so it's going to be part of the Phase 3 process. In terms of the timing of the Phase 3 process, a little bit unknown. Probably, once they come back, maybe May, June, July, the summer months, I think would be kind of the targeted time period for this. But we'll see, again, how it would work. In terms of actually getting those 8+ Democratic votes, maybe an uphill battle. We'll talk about the CBO score that came out yesterday, very negatively received from the Democratic side and from many Republicans too. President Trump has said that he would hold rallies in stadiums in right-leaning red states like West Virginia. West Virginia has a Democratic senator out there who's up for re-election in 2018. President Trump has said he's going to go to West Virginia University and rally in West Virginia University Stadium, football stadium, and try to put pressure on the Democratic senator to support the Phase 3 process to get that vote. So he's going to have to do this in 8 different states in order to get up to 60. Query whether that's actually going to happen or if this is actually more of a threat in terms of things which won't really ever happen. Can he really flip 8 Democrats in the Senate for the Phase 3? I'm kind of doubtful that would actually occur. I think the Democrats are much more likely to be unified over this position, and they're getting some backing from the Republicans, because you're seeing Republican pushback on these plans here too. So it seems like it's a little bit theoretical to me. Other things which are going on right now, kind of in parallel, at the bottom of the slide, we mentioned a few other things. There's 3 bills which are pending. None of them have any major employer impact. They're all things that the insurance companies want, like verifying that people had a status change when they go out to apply for individual coverage through the individual marketplaces. Again, interesting, probably helpful for the insurers. No significant employer impacts. We'll skip through it. All right, AHCA. So let's walk through AHCA in terms of what it would do exactly. Introduced March 6th. So again, very timely, introduced last Monday of last week. Initially somewhat tepid support from President Trump. Now he says that this is the bill that he's going to use to push this through. But he also said when the bill was introduced that it's open for negotiation, kind of indicating that this might not be the bill, that this might be kind of a starting point. And I've been trying to track this in our slide deck here, as you'll see. Then on, I think it was last Friday, Sean Spicer, White House spokesperson, said there will be no negotiation. So Trump initially, introduced the bill on Monday. On Tuesday, Trump says it's open for negotiations. Friday, Spicer says it's not open for negotiations. Then yesterday, if you saw it, President Trump said we're going to have a big, fat, beautiful negotiation over this bill. So we got no negotiation, no negotiation. Now we're back to negotiation, I think. So is this the final bill or is it not the final bill? I don't know. Check in, tomorrow in terms of how this is going. So right-wing Republicans, the Sunday talk shows, threatening to torpedo this bill. Why? What don't they like about the bill? Well, one of the things we'll talk about is it does provide for the federal government to have a role in health insurance coverage and helping to pay for health insurance coverage. It has subsidies for people making up to $75,000 individually, $150,000 as a family. You get full subsidies to go and buy your own individual health insurance policies. Subsidies are not huge. They're lesser than what they are under the ACA. But again, the right-wing coalition of the Republicans say government shouldn't be doing anything to assist at all. We have a real problem with that. They also have a problem with Medicaid expansion sticking around for 2 more years, not being repealed until 2020. They want it gone in 2018. Again, the House leadership is saying, no, that's too dramatic of an effect. We've got an election coming up, next year in 2018. Let's try to push the pain off for another couple of years. In terms of what we think this really will be the Republican bill. I think they probably will make a push for it. Speaker Ryan keeps saying over and over again to the Republicans, you have a binary choice, is the term he says. You either vote for this bill, which is out there, or you suffer under the Affordable Care Act forever. This is our one shot in our lifetime to change the ACA. You better agree now, or we're going to say that it was your fault that the ACA remained in place. So what's in it? Many of these provisions deal with non-employer specific items, so we'll kind of walk through them quickly here. For example, block granting Medicaid. So the federal government being in charge of making all these Medicaid payments, just give money to the states. The states can then deal with Medicaid as they want. The CBO projection, which came out yesterday, as we'll talk about in a little bit, says that within the next 10 years, the amount of money that would be given to the states will go down by about 25%. So in essence, it's a way of cutting Medicaid funding. Medicaid, of course, being the funding that we provide for disabled folks, low-income folks, et cetera. It would eliminate about $600 billion in taxes, according to the Tax Policy Center. CBO report from yesterday, I think, pegged the number at a lesser number. I think it's closer to $400 billion. This Tax Policy Center, where I pulled these numbers before the CBO report came out, said that the average tax cut for households in the bottom 90%, so not in the top 10%, those who make $208,000 or less, would be zero. So 90% of the country wouldn't see any kind of tax cuts. All the tax cuts basically go to the top 10%. But the top 0.1% of 1% are receiving the largest tax cuts. Not surprising, actually, because if you think about it, the ACA was financed by putting taxes on high-earning folks. So to roll them back now is kind of viewed as a huge tax cut, which disproportionately favors the wealthy. What else? This is also a way of making future tax cuts. We talked about doing tax reform later after the ACA is changed. This would drive down kind of the baseline tax revenue for the federal government, which would enable further tax cuts as part of a different reconciliation process for tax reform. Paul Ryan's talked about a $3 trillion tax cut. Donald Trump has talked about a $6 trillion tax cut. Again, they have to do health care first before they can do kind of those larger tax cuts. All right, employer impact here. A couple things to note. First of all, the individual mandate penalty would drop to zero. Again, they can't get rid of the individual mandate, but the penalty would go down to zero. Also retroactively effective back to January 1, 2016. So very interesting. Actually would be retroactively effective. In terms of dealing with this adverse selection risk, insurance companies would have to charge 30% surcharge for individuals who don't have continuous coverage. If you have a 63-day or more gap in coverage, when you go out to buy your individual policies, the carriers would have to charge 30% more. 30%, where does that number come from? Number is sort of a number that some analysts have suggested is kind of the typical cost of late enrollees. The counter argument is that the number actually is going to be higher, that if I know that I need a knee surgery in 6 months, I'm not going to sign up today and pay my 30%. I'm going to wait until month 5, and then I'll sign up. And again, I'll pay a 30% surcharge for the month where I need my knee surgery, but then I drop my coverage. I simply stop paying for it. So the carriers are very worried that 30% is too low, that it should be a lot higher than that, and so they're very nervous about that. The concept of continuous coverage, again, for employers, it means that there's going to be some reporting of coverage. You're going to have to tell the federal government, you're going to have to tell individuals, did you have continuous coverage without a 63-day gap in coverage? So you probably need to do some kind of month-by-month reporting. Did you have coverage for each of these months? If you didn't, how much of a gap did you have? You're probably going to have to produce that to employees, send it to them. It's possible it'll be built into the Form W-2. The W-2 doesn't have that information right now, but they may sort of take some of the bits and pieces you're used to from the HIPAA Certificate of Credible Coverage, which you may recall, or like the Form 1095-C, which you filled out, may take pieces of that and throw it into the Form W-2, so your W-2 would change, and that's how you report it back out in terms of continuous coverage. We'll see. Also, there's no minimum value requirement for this coverage, so it looks like even bare bones coverage will satisfy this requirement. We had again, kind of a tangent point here. A couple of years ago, I had a client ask me if it's okay to have a health plan where the only thing that the plan covers is vaccination. That's the major medical plan that they have. If you walk out of here, you get hit by a bus, we don't cover that. If you have cancer, we don't cover that. we cover your vaccination shots. And that was their major medical plan. And, ACA problems, with that kind of plan. But under this kind of plan, I think that might work, that would help employees avoid the 30% surcharge, even that bare bones kind of plan. The insurer age rating increases from 5 to 1 to 3, up to 5 to 1 from 3 to 1. Again, good for younger folks. This will mean that the older populations will have to pay more, but it'll help draw in the younger folks, is the theory. As you can imagine, if you're asking the older folks to pay more, the lobbying groups for the older folks, AARP, are running around with their, pulling out their hair, saying this is terrible, and so you're getting pushback from that, usually very important, lobbying type of block. Again, mainly an issue for individual policies, not employer side. Tax credits. I mentioned how there's tax credits under the AHCA bill here. Tax credits which would allow individuals to buy policies $2,000 to $4,000 from the youngest all the way up to the oldest folks. So again, $2,000 to $4,000, cap of $14,000 per year per family. It does vary by age. So for example, if you're under 30, it's a $2,000 tax credit. If you're at 60 plus, it's a $4,000 tax credit. So it does vary a little bit by age. There's also an income phase out, as I mentioned before. The phase out starts at $75,000 for individuals, $150,000 for family. And then once you hit that phase out dollar amount, the amount of the credit goes down by $100 for every extra $1,000 in income. So it's completely gone if you're a single person by about $100,000, which from an ACA perspective is very interesting. Under the ACA, if you're an individual, it phases out by about $50,000. Under the AHCA, it phases out at about $100,000. So you're seeing people who are single making between $50,000 and $100,000 getting some assistance to buy health insurance coverage. Well, in the past, they got no assistance to buy health insurance coverage. So that's sort of one of the winners here under the AHCA is people who are making a little bit more money, kind of middle class or upper middle class folks. What else does it do? No credit per month if you're eligible for other specified coverage. Other specified coverage is coverage under a group health plan, excluding accepted benefits and COBRA. So from an employer perspective, you're going to have to figure out if somebody is eligible for this other coverage. We'll talk about that in a slide or two. It's probably going to mean that you're going to have to track whether someone is eligible, for example, under your health reimbursement arrangement, an HRA, which I think would be other group health plan coverage that would make your folks, your employees, ineligible for this coverage here, including potentially a spouse or kids, et cetera. It'll be interesting to see what happens in terms of how they further define this. Employee assistance plans, health FSAs, wellness plans, will they be impermissible coverage that will cause tax credits to be denied? I suspect not, but we don't have a full definition on some of these things yet. Winners and losers under these changes in comparison to ACA coverage. First of all, will there be winners and losers? HHS Secretary Tom Price said a couple days ago, nobody will be worse off financially under AHCA. Nobody actually believes that, by the way. So in terms of who the actual winners and losers are here, let's walk you through the Kaiser Family Foundation projections in a couple of slides. Before we get to the slides, I wanted to walk you through the CBO report, which just came out yesterday afternoon, which clearly indicates that there will be winners and losers here. CBO report makes it more difficult, I think, to pass AHCA. What is the CBO? Nonpartisan federal agency that, again, predicts economic and other effects of legislation. So they're kind of the neutral scorekeeper for these different bills in terms of figuring out what is the employer impact, what is the impact on individuals. The Republicans have spent the past week kind of anticipating a bad number here from the CBO, so they've been talking about how the CBO was inaccurate in its first round of ACA predictions, which they sort of were, but they were actually pretty close. Hard to predict exactly how it would go, I guess. It's currently run by a Republican who was handpicked by the Republicans in the House. So, this is a fairly neutral type of group here. Anyways, their bombshell predictions from yesterday 14 million fewer Americans with insurance in 2018, so within a year, 14 million people lose coverage. 24 million by 2026. Much of that in the individual market and Medicaid market, but they are predicting a 3 to 5 million employee decrease in employer-sponsored coverage. Why? Again, if they get rid of the pay-or-play rule that mandates that large employers have to offer coverage, some large employers will drop coverage. If they get rid of this full-time employee rule, they have to offer coverage to people working 30 hours a week. If that disappears too, as it would under AHCA, then some of the employers who are out there will drop that coverage, right? We'll go back to offering coverage to maybe 40-hour-a-week people, but we're not going to offer it to 30-hour-a-week people. So there'll be some overall loss. There's also some tax credits, as we'll talk about here, which I think will influence employers too. So again, kind of a decrease in employer-sponsored coverage, we think is not what CBO, with the federal government, thinks will happen. Interestingly, kind of a quick side note here, Politico, which is a website that reports on political issues, claims that they saw a leaked White House prediction for this, and the leaked White House prediction actually predicted 26 million would lose coverage. So the internal White House predictions actually had it worse than the CBO in terms of loss of coverage. In terms of the premiums for individual policies, would jump up 15 to 20% in the next year, higher than they would have been under the ACA. So if the ACA would have been 10% increase this year, it'll be 10% plus 15% to 20%. By 2020, though, the premiums actually go down according to the CBO report. So by 2026, the average premiums are 10% lower than under the ACA. Why are they lower? Well, a couple reasons according to CBO. First of all, the typical losers here under the AHCA are the older, less healthy population, less income folks. Again, the credit, the $4,000 credit that they get doesn't make up for the 5-to-1 ratio, and they simply won't be able to afford coverage. So what will happen, CBO predicts, is that the older population, which tends to be less healthy, will drop out. They'll simply be uninsured. And then you have a pool of younger, healthier folks who will end up with coverage. People who arguably don't need the coverage will be the ones who actually have the coverage, and that will result in a better pool. And therefore, insurers by 2026 will be able to drive down the cost because they won't be covering the less healthy folks. Is again what CBO is saying. What else does it do? Reduces the federal deficit by $337 billion over 10 years. That's very helpful from a Republican perspective. It basically means that they can go forward with the reconciliation process. They had to have a number that reduced the reconciliation by at least $2 billion. They came out at $337 billion, so they can go forward with the reconciliation process. How do they do that? Again, Medicaid cuts. Again, by 2026, a 25% reduction in Medicaid expenses. That is how we're basically paying for this. All these different subsidies. We're cutting off the aid for the poor and the disabled to give money to the middle class and upper middle class. Republican reaction is varied. Paul Ryan yesterday praised portions of the CBO report. He says, I'm pretty encouraged by it. It actually exceeds my expectations. I assume he's not talking about the loss of 24 million people being covered. I assume Paul Ryan is talking about the $337 billion in savings, that exceeded his expectations. But he's a little bit unclear on that. The White House, so he's kind of accepting the report and saying, yeah, this is good news. White House rejects the report. So again, even though they have this kind of leaked document that says that they actually predicted more, HHS Secretary Price, he strenuously disagrees with the report. He thinks there will actually be a gain in coverage, is what he's saying, that more people will have coverage, so it won't be a 24 million loss. There'll be some unspecified gain in coverage here. He also criticized it for failing to consider phases 2 and 3 here. Phases 2 and 3, again, can't be taken into account because there's no legislation introduced yet, so it can't really be taken into account yet under CBO rules. Most other Republicans who commented, a fair number of Republicans said that they haven't read it, that they're not commenting yet. Other Republicans said that they've got some work to do here. Senator Gardner, Senator Hatch, who's concerned about it. Democrats, of course, jumped all over this and used it to beat up on Republicans. One CBO example that kind of caught my eye in the report, 64-year-old earning $20,000 sees her premium cost go from $1,700 under the ACA to $14,600 under AHCA, a 750% increase. So this is the one that I think kind of caught my eye. Again, if you think about a 64-year-old earning $20,000, arguably, if you look at the voting data, may have been a Trump voter. If you look at some of the polling that's out there, and that person really sort of gets hammered under this proposal here. We also were able to pull together some Kaiser Family Foundation winners and losers here, and so let's walk you through the different ones which are out there. In terms of the different numbers here, this is for an individual, so lower income individual, what they get under the ACA, which is in blue, versus under AHCA, which is in kind of the orange, I guess. Age 27, ACA person making about $20,000 gets $32.25. Here, again, we're not focused on anything other than age. They're at $2,000. So again, they get more under the ACA significantly for a $20,000 per year employee. For someone who is a little bit more middle income under the ACA, you'll see the number drops quite a bit. So lesser subsidies as your income goes up. Under AHCA, the Republican bill, the subsidies stay the same, $2,000, $3,000, $4,000, only varying by age, not really varying by income at this point. So again, the winners here would be a younger person who's more middle class. They get a lot more from a subsidy, $2,000 versus only $103. When you move into the higher income individuals here, again, at this point, the ACA subsidies have completely phased out because you're above the $50,000 limit, you're at $75,000. They do a lot better. If you are a kind of middle class person here, you're making a lot more, you're getting a lot more in subsidies than you are under the Affordable Care Act. So again, the winner here at the individual level, very much kind of the middle class in terms of who's making more money. The next one here is we were showing it by varying by family and also by geographic region. So in this one, let's look at it from a family perspective. Lower income family, $40,000, middle income, $75,000, higher income, $150,000. How do they compare? And then we're going to vary it by cost here. So Reno, Nevada is a low-cost place to obtain health insurance. Mobile, Alabama is a high cost. There's fewer providers. The providers can charge more. Reno has better competition in terms of the cost. And so what we see here is in this situation, under the ACA, again, for a family of 4, in this case, it's two 40-year-old adults, parents, and 2 kids. So again, the premiums and the credits sort of stack up on each other. So you've got, in this case, $13,180 under the ACA. Under the President Trump bill, only $10,000. So they lose money here in comparison. The loss is even more significant in terms of the high-cost areas, kind of the rural areas like Mobile, Alabama. Under the ACA, someone making $40,000 gets $19,500 in subsidies, so they can buy a pretty good plan. Again, it drops to $10,000 here. Medium income, kind of similar here. Higher income folks, absolute benefits. Higher income folks get nothing here under the President Trump plan. They get $10,000. So very much an increase in that context. Very much a benefit in that setting. So Kaiser Family Foundation, which is very much a neutral organization, has a really cool interactive website. We couldn't put it up here because it actually varies. So and you can go back and do this yourself. Off to the left-hand side, you put in the income that you want to measure. So you can do it by 30,000, 40,000, 50,000, things like that. And then the age that you're trying to measure. And what it does is by county by county across the country, you can figure out who the winners and the losers are. Are you getting more as a county on average in these different areas? And so if we pull up Wisconsin here, and Paul and I were joking that it's dangerous to do live things in a webinar like this, isn't it? You're just worried about it. So in terms of the Wisconsin results here, which we thought would be more interesting, if you look at the northern counties, in general, they tend to do worse. Percentage change from ACA to house tax credit, minus 16%, minus 23%, minus 15%. So the northern counties in Wisconsin, the ones that President Trump won rather handily in general, all take a hit here. Well, if you go down to some of the wealthier counties, let's go down to Dane County, liberal capital here in Wisconsin, they make out like bandits. 101% increase for Dane County in terms of the average subsidies they get under the President Trump plan. So the rich, more Democratic-leaning counties get a lot more cash than the poor Republican-leaning counties under Republican plan. Will tax credits cause employers to drop coverage? Again, the CBO report says yes. Between 3 to 5 million employees will lose coverage under this bill. And I can absolutely see it. I definitely see it. In terms of the tax credits, I remember when the ACA got passed, how I would go around and speak to different groups, including groups of CFOs, chief financial officers, and they would have their pencils out and their calculators out, and they'd be thinking about, okay, if I pay X amount for coverage here for health plans, if I drop it, what's my penalty, things like that. CFOs are going to be very interested in these tax credits. I know that they're going to be very curious to hear about this. For example, let's kind of walk through a hypothetical. Kaiser Family Foundation, again, very good site, says that in 2016 the average family cost was about $18,100 in terms of the total cost of coverage. Employees paid about $5,300, employers paid about $12,800. So that the employer cost about $12,800 on average. Now, if we take a family of 4 here, income within that $150,000 limit for the families, dad is 42, mom is 39, and the kids are 10 and 12. What's the tax credit if the employer doesn't offer coverage to that family? The employee has to go and buy family coverage. $9,500, so $3,000 for dad, $2,500 for mom. Again, these are only age-based items. $2,000 each for the kids. So suddenly you're looking at $9,500 in federal funds which are available if the employer doesn't offer coverage. Now, if the employer offers even an AHRA, a health reimbursement arrangement, the $9,500 disappears. It's off the table. But if you don't offer anything to families, I think what could happen is the family could go out and could buy health insurance coverage here, and the employer could look at this and say, well, or the CFOs, I don't know if we have any CFOs in the room here, but they're going to look at this and they're going to say, well, wait a minute, I could save myself $12,800 by not offering coverage to this person. This person can get free money, $9,500 from the federal government. That's only a $3,300 difference. I'll pay that person $3,300 or $4,000 or $5,000 to not go on to our plan and to make it worth their while to go out and buy an individual policy. Because even if I have to offer $5,000 so that the employee is coming out ahead, that's still cheaper than $12,800. I'm saving $7,800 per employee that has a family. $7,800 multiplied by my 1,000 employees, that's a lot of money. You're suddenly talking about big bucks here. So I think the CFOs are all going to look at this and say, hey, I'm kind of interested in this. Maybe we will provide coverage for individuals, but maybe you benefit folks, you're going to have to cut back on your benefit plans, and we're not going to provide family coverage. Everyone who has a family, you're going out and buying individual family coverage, and we'll give you a little bit of a cash bonus to pay for it, but family coverage is gone. We simply don't offer it because the federal government subsidies here are so generous. We can't pass up the free money that the federal government is shoveling out here. Now, this, of course, would be within the income limits, and so you can see how maybe for the executives who make more than $150,000 and suddenly don't get those subsidies, maybe you'd have to offer some kind of coverage for them. So we'll see, and maybe this is just too complicated. Maybe this is me just kind of thinking about it too theoretically here, but I don't know. I mean, I just know from previous discussions with CFOs that if they can save money, that they'll be very interested in kind of working through this detail. So 3 to 5 million to me, loss of employer-sponsored coverage seems reasonable. I think it could be higher. I mean, I'm not a numbers guy, but I could just see how, again, there could be a significant reduction, certainly in family coverage. Single coverage, I don't know. $2,000 credit for a single 25-year-old. I'm not sure it's worth the hassle, honestly, in terms of the HR costs, the recruiting costs, et cetera. So I think that some employers may say, hey, we'll keep the single coverage, but for family coverage, these are big bucks, at least when you start having multiple kids. Now, again, it is capped at 5 kids, so if you're the Duggars with 18 kids and counting here, It doesn't go on for infinity, but clearly if you start adding up some of those numbers, the numbers do get a little bit higher. So we'll see. Obviously, you could raise some non-discrimination issues. If the coverage is self-funded for the executives, in that hypothetical, could be some 105H, Internal Revenue Code Section 105H non-discrimination rules. There is a similar non-discrimination rule under the ACA. It's never been enforced. It was supposed to kick in 2011. It's been kind of a holding pattern so far. The final point down there is, let's suppose that the CFOs all listen to this presentation. They're all like, that's a great idea. Let's all drop our coverage. And suddenly the federal government is paying a lot more than what they're expecting. Would the federal government, would the Republicans kind of reverse themselves and say, hey, wait a minute, no, let's go back to some kind of employer mandate-like rule? Who knows? If the funding kind of skyrockets higher than projected, I could see how Republicans may revisit that idea. Obviously not in there right now. Other employer impacts. The employer shared responsibility rule, the pay-or-play rule, under this AHCA bill drops to 0. Retroactively drops to 2016, not 2015. So in theory, there's some potential exposure for you all if you weren't offering sufficient coverage in 2016. But it's very nice retroactive relief here from that pay-or-play rule. In terms of the 1094, 1095, the number one question we've gotten so far is, what happens from a reporting perspective? Can I stop tracking who's a full-time employee? Can I just ignore this? The answer is no, not yet, at least. Again, this is not a law. You have to still be tracking who's full-time, still keeping track of hours, still offering coverage. So until this retroactive relief is provided, don't change your benefit plans in terms of who's eligible. You still have to be tracking that data. And I think you still may have to do 1094, 1095 reporting, even if the employer shared responsibility rule penalty drops to 0. Again, the taking away of this reporting is not part of the American Health Care Act. So even if they pass this law as it's written today, you still would have to do reporting for 2016, 2017, 2018, 2019, forever, until they get around to taking away that reporting piece of it, or until the IRS says you don't have to do anything. So now you kind of have to plan on it. One question is that's also popped up is, will coverage which was offered to the 30 to 39-hour folks be rescinded? Will it be eliminated? We did have a number of clients. We have a lot of clients who cover people at 20 hours or at 30 hours, even before the ACA. But we did have a good number of clients, too, who had it at 40 hours. And so they had to involuntarily bump it down to 30. Will you go back to 40 now? What kind of HR hit do you take? What kind of recruiting hit do you take by taking away health plan offerings for those who are between 30 and 39 hours? And do you care? Maybe you care, maybe you don't. It kind of depends upon how easily replaced some of those employees are. Will they be so disgruntled that they would consider leaving, if you took away coverage for a 35-hour employee? If you collectively bargain, don't forget the collective bargaining issues associated with it may be locked in for a couple of years and may not be able to turn on a dime like the non-unionized workforce. If your eligibility rules do reference measurement periods, you may need to eliminate those references at some point here too. New reporting. I mentioned this before, how employers, we think, are going to have to probably report on the W-2 whether on a month-by-month basis an employee was eligible for other specified coverage. We think that that's a better system than what the 1094, 1095 stuff is reporting. 1094, 1095 is very complicated. This seems to be a lot easier in general. For January, were they eligible for coverage? Yes or no. February, yes or no. So it seems simplified. We do think it could raise some tracking issues, which may be difficult. For example, let's suppose that an employee previously declined coverage. Maybe they were, single and didn't have any kids, didn't have any spouses, and then suddenly they get married, or suddenly they have a child. From a HIPAA perspective, that's a special enrollment event, right? So they have the ability to get onto your plan, so they are eligible for a certain time period, a couple, months or two or whatever it is. So they have this eligibility. I think that means you probably have to report them as being eligible for those months because of the HIPAA special enrollment. One difficulty, though, is employees don't always tell you about that, right? And so, especially if they're not on your health plan, if they have a child, why would they need to tell you? So it could create some reporting issues where they theoretically be eligible for coverage, but there's an information gap. You wouldn't know that they're eligible. You wouldn't have the right information to report it on the W-2. Presumably, the IRS would give us some relief in that situation where employers would not be liable in that case. There's also in the statute a provision for a mid-year reporting upon request of the employee. So if the employee comes to you and says, "Hey, I need that report showing you've had continuous coverage, showing what the offers were," you're going to have to provide it to them. We don't know the form. We don't know how quickly, 30 days, 10 days, what do you have to respond? Again, all that would be kind of determined by regulation, assuming they can issue regulations. Over-the-counter impact. Over-the-counter rules, again, kind of drove employers crazy under the ACA with needing some kind of prescription, unless it's for insulin. That rule disappears effective January 1, 2018. That would be going away. So that's good. Probably will require some kind of amendment to your plan, maybe in the tail end of this year, 2017, again, assuming this goes forward and becomes law, or perhaps in early 2018, you may have to handle that. ACA and retiree drug subsidy. There's kind of a complicated drug subsidy tax change which is out there, which is sort of a reduction in the amount of tax that you could claim if you're getting retiree drug subsidy funds from the federal government. This would flip that, would allow you, the employer, to take bigger tax deductions, so it'd be better for you effective January 1, 2018. Cadillac tax. The Cadillac tax would be delayed until 2025. This is great news from an employer perspective. You probably all recall how under the ACA, there's this 40% excise tax on the cost of high-value health plan coverage. So again, if if the magic number is, it's $27,500 under the ACA. If you offered a $30,000 family plan, you take the difference between $30,000 and $27,500. That's $2,500. You take 40% of the $2,500, which is $1,000. That's a non-deductible excise tax that you as an employer have to pay. Nobody likes it. Democrats don't like it. Republicans don't like it. Nobody likes any taxes, I guess. And so it's got no natural base, but it is a good funding source for purposes of writing these bills. And so Congress initially said, let's make it effective in 2018. That pushed out to 2020. This pushes it out to 2025. I kind of suspect we'll probably never see it, but at some point they'll come up with the money, and this whole thing will be pushed out another 5 years, and then I retire. Then I don't care anymore. So, I could see this kind of following my career here. So we'll see. But again, who knows where it'll go eventually. Earlier leak draft would have taxed the value of employer-sponsored coverage at a 90% level. I mentioned this before. That fortunately was dropped from the final version. There had been a leaked version of this. Politico had published the full leaked version of it. We'll see. The next bullet point you can kind of ignore in terms of CBO score. We've gone through that. And we'll see, does the Cadillac tax will actually bend the cost curve, or is this just to generate revenue? Will this help drive down costs? I don't know. HSAs. HSAs are boosted. Again, I mentioned how Republicans love HSAs. The maximum contributions here under AHCA to HSAs really goes up significantly, $6,550 for self-only, up from $3,400, and $13,100 for self plus one or family, up from $6,750, effective January 1, 2018. So a lot more that you can stick into your HSAs, of course, if you have the money. They're very nice tax savings vehicles. Also, both spouses can make catch-up contributions to the same HSA, effective January 1, 2018. And then there's a little kind of a nuanced rule saying that if you have a medical expense, let's suppose you have a medical expense today here, March 14th, and you don't get around to setting up your HSA until next week, can you claim that medical expense under your HSA? The current law is no. The medical expense has to be incurred after you set up the HSA. This would give you a 60-day kind of grace period, so you could kind of bring in those claims. So if you end up with a big, $10,000 claim, you don't have an HSA, you run down to the bank tomorrow or next month or whatever. You have 60 days to kind of retroactively establish an HSA to pay for that $10,000 on a pre-tax basis, which is nice. I think it's great. It does raise some questions about whether that's kind of a one-time opportunity to take the 60 days, or could you take advantage of it if you close an HSA? Could you redo it? Who knows? So there's some open questions with it. but in general, very positive from an employee perspective and employer perspective. Non-medical distributions from an HSA, currently subject to a 20% excise tax. If you take out funds for non-medical, would drop to 10% under this bill. Health FSA contributions, the cap would disappear. Right now it's capped at $2,600 in terms of the employee contributions. Again, that would go away effective January 1, 2018. Probably need some IRS guidance in terms of how to deal with mid-year changes. If you have a non-calendar year FSA that starts, July 1, and this rule kicks in January 1, 2018, how you can handle that? You need to give employees a new special enrollment opportunity or some ability to change their election for the non-calendar year folks. So again, there could be some issues with it, but overall we think very positive. COBRA subsidies. This is very interesting. This is a brand new concept, not in the ACA and not floated by any of the previous bills that we talked about, the Price bill, the Ryan bill, et cetera. What they're saying here is that tax credits, those tax credits we talked about, $2,000 to $4,000, can be available for unsubsidized COBRA coverage. So if you have an employee who quits or you fire an employee, the federal government will now help pay for the cost of COBRA coverage. Again, very helpful because COBRA coverage is usually fairly expensive, of course. What do they mean by unsubsidized? Unsubsidized under the statute, no portion of the premiums for which are subsidized by the employer is their definition. Now, that's pretty circular to me in terms of what that term means. And we can see how there could be some issues. A lot of times you'll enter into a severance agreement with a former employee. You give them $2,000 a month. If the cost of COBRA happens to be $2,000 a month, are you subsidizing the cost of COBRA if the dollar amounts match up penny for penny? Are you not subsidizing it if the dollar amounts are off by a penny? Who knows? So there could be some issues in terms of what exactly it means to be unsubsidized. But assuming we get some guidance on that and we can kind of get around that issue, it's very helpful, again, to have this kind of subsidized COBRA coverage, I think in general, certainly for your employees. COBRA includes, for these purposes, state continuation laws. So if you're a small employer, less than 20, not subject to COBRA, you're subject to Wisconsin's mini COBRA law, for example. It would also apply in that context, too. There are some limits. It's not available for a health FSA. It's not available for an accepted benefit plan like a dental plan or a vision plan, so there are some limits in terms of it. Married couples, for some reason, have to file a joint return in order to claim it. Plan cannot be grandfathered. Again, kind of from an employer perspective, that's sort of odd. That means that the whole concept of being grandfathered under the ACA may not go away. You may still have to keep track of that. You may have to note that, for example. Now, if you're already lost your grandfather plan status, as most employers have, it may not be a big deal, but if you're trying to keep it, you probably have to track that and continue to follow those grandfather plan rules. Also, the plan cannot cover abortion. This is very interesting. Other than what's necessary to save the life of the mother or due to rape or incest, those are the really only exceptions out there. So, again, you're kind of seeing the Republican base, I think, throw that kind of provision in there, putting pressure on employers where if you want your employees or former employees to get this kind of subsidy, this is the carrot that they're giving you the subsidy, but this is one of the sticks. You may have to modify your plan to get rid of abortion, except for in those cases. It also raises some questions in my mind about how much detail you're going to have to get into, because the plan administrator has to certify that you meet all these rules. So you, if you're the plan administrator of the plan, or the company is, et cetera, somebody's going to have to sign some document, it looks like, and send it to the federal government saying, yes, your plan meets these rules, including the abortion rules. So you're going to have to maybe delve into the details of that. Time, place, and manner for sending out this notice to be determined. All right, so what remains of the Affordable Care Act? Well, again, little things I sprinkle in here throughout the presentation. Potentially need to know on the last slide whether your plan is grandfathered, et cetera. But in general, if you're going back to the office and trying to explain it to folks, think of it like this. This is not a full replacement. This is not a full repeal. This is phase one of a multi-phase process. And in general, the vast majority of the ACA remains. It was a very long bill, hundreds of pages long, has a lot of different things that employers have to do, modifications to your plan. Basically, the vast majority of those stay. Individual mandate goes away, employer shared responsibility rule goes away, but all the substantive details basically stay. So no annual or lifetime limits on essential health benefits. You've been following that rule for a couple of years now. Again, that remains. No pre-existing conditions. So you can't, again, throw in pre-existing conditions. No excessive waiting periods. Generally, that 90-day waiting period remains. The expanded claims and appeal rules with an independent review organization, an IRO, that remains. Preventative care coverage, first dollar, remains in general. Now, again, on the next slide, I think we'll talk about how it could be tweaked. HHS Secretary Price could say, you know, we think that some of these things are not really preventative care. He may cut back at some of those things, but the broad concept remains. You know, well baby visits, child immunizations, absolutely, I don't see any changes whatsoever there. Those are going to remain first dollar. Covered kids until age 26, bipartisan support across the board for that. No rescissions of coverage, summaries of benefits and coverage, SBCs. Increased wellness plan discounts. You know that we can go up to 50% now under the ACA rules for the wellness plan discounts. The Section 1557 non-discrimination rules, we'll talk about those more later. We have a slide on that. Many of these other suspended or ignored ACA provisions. I mentioned the non-discrimination rules for fully insured, non-grandfathered plans. Should have kicked in 2011, still have not been released, probably will never be released, but they are still in the books and they don't get taken away by AHCA. Certification of HIPAA compliance, there's some technical rules out there. Again, all those remain. So bottom line, essentially ACA remains in full force and effect unless specifically noted. And again, from the employer perspective, it's mainly the pay or play rule. All right. One last kind of wrap-up slide here on this. What else could be coming here? Or maybe we have just one more wrap-up slide on this. What else could be coming? Again, I mentioned preventative care benefits, I think, could be modified. We can see an expansion of the religious employer exemption. Some religious employers, like Hobby Lobby, for example, have said that they shouldn't have to provide contraceptive coverage. We could see that being expanded. What exactly is an essential health benefit? That's kind of a vague, undefined term. We think that that could be changed. Selling insurance across state lines. Again, Republicans love the idea of this competition. They think it'll spur better prices, and competition usually does spur better prices. So the selling of the insurance across state lines absolutely could be part of phase 3. QSARAs, the Qualified Small Employer Health Reimbursement Arrangement, again, we think could be maybe even expanded. Right now it's capped at 50 full-time employees in terms of the employer size. Could go higher than that. Further expansion of HSAs are possible. Privatizing Medicare, again, not a big employer impact. Other changes once the insurance industry reacts, we could again see the insurance executive saying, hey, this doesn't work for this reason, this doesn't work for that reason, can you tweak this, can you modify that? You know, there could be some changes like that. The big question, though, I think is, you know, will this actually work? And if, when I say that, you know, what are the goals? What is it supposed to accomplish? What's kind of the intellectual theory here? I don't know. HHS Secretary Price was asked this a couple days ago, 2 days ago, saying, you know, how would we know if this bill is successful? He said it means more people are covered than are covered right now at an average cost that's less. You know, so that may be, if that's the measure of success, we'll see. Again, the CBO report, 24 million are not going to have coverage. You know, some voluntarily, some involuntarily. Average cost, again, the CBO report says in 10 years the premiums could be 10% lower. So again, we could get to a point where the premiums are lower, but the number of people who are covered is less. So, you know, it's kind of a trade-off in terms of where we as a country want to go. All right, so a couple other sort of pending bills here that we just want to mention, 3 other pending bills. March 9th, the House Committee on Education and Workforce approved 3 bills. The Preserving Employee Wellness Programs Act. This is one that would help clarify that as long as you're following the HIPAA non-discrimination rules, the HIPAA wellness rules, that you won't be violating the Americans with Disabilities Act or GINA regulations. You may recall how in, it was May or June of last year, the Equal Employment Opportunity Commission, the EEOC, came out with some fairly stringent new wellness regulations. And this would basically say, hey, as long as you are following the other set of wellness regulations, the old 1997 IRS, DOL, HHS wellness regulations, then you'll automatically be deemed to satisfy these new, more stringent regulations that came out last year. So in general, it is a pro-employer, pro-wellness type of bill, which is moving through there. It has taken some heat. NPR, New York Times, Washington Post have criticized it because it would essentially allow you as employers to, as it's currently written, get access to the full genetic information of employees. So and let me take a step back. GINA, Genetic Information Non-Discrimination Act, most employers are not aware of it, but it was, again, part of these regulations. It generally says that you as employers are not supposed to get the genetic information of your employees. Interesting history on it, again, kind of a tangent. It was enacted over a decade ago by Congress because one of the big railroad companies here in the United States was forcing its employees to give snippets of their hair to HR, and then HR would run a test on their genes to see if they're genetically predisposed to various illnesses. If they were, then they fired the employees. Congress said, wait a minute, we don't necessarily want employers, getting access to this, so let's cut off their access to genetic information, and we certainly don't want them misusing the genetic information once they have it. And so they passed this GINA bill saying you generally can't do that. Very fine. I think most employers understand you can't really, discriminate against people on their genetic makeup. So this bill, the way it's drafted right now, kind of changes that. It says that you still keeps in place the piece saying that you can't discriminate against your employees, but the way it's written, I think, would allow you to actually collect the true genetic data of your employees, their spouses, and kids. And it does raise the concern that's been noted by the privacy advocates that, hey, if employers are really getting access to all this genetic information, true, in theory, they're not supposed to misuse it, but are we kind of making it too easy to misuse? Well, some of the worst employers out there, if the data is just sitting in folder number 1, will they open it up and say, who should I fire today? We need to do a reduction in force. Will they target some of these folks? I don't know. So, and it's kind of unfortunate. I mean, I think most employers want to be able to do like blood draws and figure out cholesterol levels and blood sugar levels and things like that. That I think is well accepted among even most privacy advocates. This would codify that and say, yeah, that's fine, but then take it a little bit further with the actual genetic information. And that's where they're getting pushback, I think, by the privacy advocates. So we'll see where that one goes. Small Business Health Fairness Act. Small employers can band together in association plans and provide self-insured coverage. I think would be very helpful. I know there's a lot of small employers that would love that concept. Chamber of Commerce type plans banding together. The Self-Insurance Protection Act clarifies that stop loss generally is not health insurance. What does that mean? It kind of deals with some of the state regulations of stop loss coverage which have been going on. All right. So let's jump ahead to kind of other sort of grab bag of topics and issues for employers here. Data privacy and security, want to mention a couple things. Office for Civil Rights, HHS, has been on, I don't want to call it a rampage, but they have been very aggressively enforcing the HIPAA rules. They've begun phase 2 audits, which are primarily desk audits, but some on-site ones are occurring. Impacts both group health plans and business associates, so whether you're a vendor to a group health plan or a group health plan yourself, if you actually have a group health plan, which I think everyone here does. Again, you're going to be subject to HIPAA. Common problems, lost laptops. If you have any employee who's able to put protected health information on a laptop, you should probably stop that practice or make sure that the laptop is encrypted so that it can't be easily accessed. The data on there is encrypted. Lack of training. HHS has been beating up folks over not training employees on HIPAA, including like new employees. So again, if you have a new person in your benefits group, new person in the HR group who's going to be seeing protected health information, how quickly do you need to train them? General rule is probably about 30 days. Nothing in the regulations gives you a hard deadline, but some of the settlements that we've been seeing indicate they have to have training within about 30 days after joining the organization. Failure to conduct security assessment, et cetera. Most recent kind of big penalty which caught our eye, $5.5 million penalty against the hospital for breach involving 115,000 records and failure to terminate the login privileges of former employees, about 14 former employees. In the past, that would not have been a $5.5 million penalty, in my opinion. Probably would have been $1 million penalty or something like that. HHS, again, very, very interested in terms of enforcing some of these rules. They've also issued some ransomware guidance last year, clarifying that if you have a ransomware attack, it probably is a HIPAA breach. By ransomware, what I mean is we're seeing, and we do have some clients who've been impacted by this, nefarious hackers, et cetera, get into your system. They don't take all the data. What they do is they put in an encryption program, so all your information, all your employee records, all your financial records suddenly become garbage to you. They're encrypted. They demand a $15,000 Bitcoin payment to them, and if so, they'll give you the decryption key. They'll unlock all your own data. We've actually had several clients impacted by this, most of whom have agreed to pay the $15,000. But in terms of their general position is that if you are hit by it, unless you can demonstrate a low probability that the PHI has been compromised, then you have to determine, or you have to take the position that you do have to report it, that it's a reportable breach at that point. This raises lots of other questions. How do you determine that? Probably need an IT consultant's opinion. Should ransomware be reported to the FBI? We've been talking to some folks about that. In general, the FBI, we went to an FBI presentation in Milwaukee a couple weeks ago. FBI agents said in general they do want reports sent to them. They said that once they get to 100 reports, then they take action. They kind of open a case on it. Before they get to 100 reports, unless you're a major entity, they basically kind of put it in the let's look at it later file. So there's strength in numbers. If you've been hit, even if you're not big, if there's 99 other folks, FBI will take a look at it. There's also a nomoreransomware.org website. We can upload kind of a portion of the file, and they can tell you right away if there's a known decryption key that's out there, because there are some known kind of decryption keys which are out there too. Cloud service providers are business associates, so if you have things stored in the cloud, you need to have a business associate agreement with them. And then the ERISA Advisory Council, which is a Department of Labor appointed council made up of employers, basically, and others who give advice to the DOL on how to enforce some of these rules, issued in November a cybersecurity considerations for benefit plans. What should employee benefit plans, both health and welfare and retirement, be thinking about in terms of some of these issues? And I thought I'd put it out there and kind of walk you through this quickly here. Establishing a strategy, so working again with your IT group so that the information that you have some strategy about where the information is, what risks it's subject to, what are the protocols for keeping it secure. Contracting with your service providers to make sure that their security obligations are known. Identify reporting and monitoring responsibilities, conducting periodic risk assessments, verifying if your provider has a cybersecurity program. And this does happen, although I don't do much retirement plan stuff anymore. We have some of my colleagues who do it. Just last year, we had a major national vendor to retirement plans, the 401k plans, have a breach situation. Hackers got in, stole a bunch of social security numbers, names, things like that, financial account numbers. And the question is, who's going to pay for the notifications? Who's going to send out notifications? Who gets to put in the wording, et cetera? So there was nothing in place with that vendor. We kind of had to negotiate with them. It would have been better from the employer perspective if we had kind of pre-negotiated all that ahead of time rather than waiting for the breach. Cyber insurance policy is very popular, becoming more popular. Two recommendations to the DOL from this group. First of all, make the report available to plan sponsors, which they did. That's how we know what they said. And then ask the DOL to provide further guidance to the industry in terms of ERISA fiduciaries. What is your fiduciary duty to keep this information secure? Is there a fiduciary duty? And if so, how do you satisfy it? To date, the DOL has not issued that guidance. We'll see if they ever do provide something out there, but it's a little bit worrisome that we do have this kind of guidance, this kind of semi-official guidance. It does, I think, arguably mean that you should be looking at it from a due diligence perspective. A couple other quick questions. State privacy laws. A lot of times we'll have health plans that have breaches, or your TPA has a breach. The question comes up, do we have to follow state laws? There's 50 states, 47 of them have data breach reporting laws, usually triggered if a Social Security number is breached. Do you have to follow them, or can you ignore them and just do HIPAA? And our general position is that we think that you can ignore them. We think that most clients can just follow HIPAA. You don't have to deal with 47 different states. There was also a recent Supreme Court case from last year, Gobeel, which sort of supports that analysis. Gobeel involves some different reporting issues, not data breach reporting issues, but some claims reporting issues, and the Supreme Court held that those kinds of laws were preempted by ERISA. So we think the logic of that would stretch to data breach also. And also, finally, there have been some reports of plans being victims of various electronic attacks. In November of last year, the UFCW Local 655 pension plan publicly stated that it was a victim of a ransomware attack. Often leads to litigation here, but the harm has been difficult to show so far. So if you are ever sued over this, which would be bad, and hopefully, again, you've kind of thought about it in advance, you got your insurance, et cetera. But in terms of the harm that the plaintiffs would have to show, so far courts have said it's very hard for you to show the harm unless you can actually prove that your identity has been stolen, or people have applied for credit cards in your name, something like that. Unless you can actually show damages, in general, courts have not been very sympathetic to plaintiffs. So that's kind of the positive side of this. No one wants to have their employees' information misused, but if employees sue you, it's difficult for them to prove damages. Other kind of changes here. So let's go through some other changes which have popped up here. QSARAs, we want to spend just one slide on this because, again, this is a small employer issue, probably doesn't impact too many folks here. But as part of the 21st Century Cures Act, which is a December 2016 law that came into being, giant law, one of the last, probably the last major law signed by President Obama, one little provision in there allowed for qualified small employer health reimbursement arrangements. What are those? In the past, some small employers have not wanted to establish formal group health plans. They've just told their employees to go out and buy individual policies, and we'll reimburse you for those individual policies. So, go out and spend up to $2,000 a month for family coverage. We will reimburse you the $2,000. Under the ACA, that was very difficult to do. IRS cracked down on that, said that that's illegal, subject to massive penalties. This kind of reverses that and says, hey, small employers, if this is how you want to provide health insurance coverage to your employees, go for it. This is the legal method for doing that. So, again, if you're in that, or maybe you have a subsidiary that's in that business, do take a look at this as a potential option. It's pretty clear that these are not group health plans under COBRA, ERISA, et cetera. That's generally good, I think. Could make you subject to state laws, but we'll see. There's some hoops you have to jump through. You have to give employees an annual written notice at least 90 days before the start of each year that you're going to have this kind of QSARA plan out there. For 2017, we're already into 2017. No one could have met that time period, so the IRS has waived it for 2017, pending further guidance. The funding for these has to be through employer contributions, not employee contributions. So there's no pre-tax funding of this. Employees can't contribute like they do on the health FSA side, can't contribute on a pre-tax basis here. Some non-discrimination rules do apply. And again, right now the big kicker here is that it's only for small employers. Small employers defined under the Affordable Care Act, which means 50 or fewer, less than 50 full-time plus full-time equivalent employees. Query whether this could be expanded to large employers too. Again, that's one of the things that Paul Ryan has talked about in his Better Way, is opening up HRAs even to large employers so that you can just say to your employees, go and shop around, find your own coverage. And we'll reimburse you up to X amount. ACA, Section 1557. Section 1557 is one of these rules that, again, kind of impacts only a smaller number of folks. But if it impacts you, you have to look at it. Where it technically applies to health programs and activities that receive certain federal financial assistance. It applies to the insurance companies when they're selling policies on the exchanges because they're getting the federal funds. At the employer level, when does it ever apply? first of all, it could apply if you are a healthcare provider. So if we have any hospitals, et cetera, you no doubt are getting federal funds because you're getting Medicare and Medicaid payments. So probably applies to you as an entity, probably also applies to the health plan that you offer to your employees, because they're kind of conjoined together. So again, if you're a healthcare provider, it probably applies. If you are receiving Medicare Part D subsidies, so if you have a retiree drug program, federal government will help pay for the cost of that retiree drug program, they're giving you federal funds, you probably are subject to this rule also. Unless you fall into one of those two categories, you probably are not subject to this rule. You can tune me out for the rest of slide 34 here. Then you have to pay attention starting at slide 35. But slide 34, again, fairly narrow focus. If it does apply, you can't discriminate on the basis of race, color, national origin, sex, age, or disability. Now, very few plans intentionally discriminate. It's not like you say, you know, we cover men but not women, or we cover, you know, this racial minority but not that racial minority. So it's very strange if you look at it on those words, like, well, how would that ever apply? The one area where it does apply, or could apply, is according to the regulations, it's sex discrimination if you don't cover gender reassignment surgery. So it's a discrimination against transgender individuals. Many plans don't cover that surgery. They view it as kind of optional, cosmetic, et cetera. And so it's a big change if again, you have to start covering this. Or it's potentially big. The actual dollar amount in terms of the cost, I've seen some estimates from some of the carriers out there. I think they said it's like 10 cents per employee per month in terms of the cost. So it's not a huge dollar amount, simply because it's not used that often. But you potentially have to at least look at it and modify your plan for it. Now, there is one tweak to that. On December 31st, 2016, one day before the regulation was set to kick in, there was a court down in Texas that put a stay on this rule, or at least this aspect of the rule. So for now, I think you actually don't have to cover transgender reassignment surgery until that court order is lifted. It does beg the question of, well, if they lift it on a Tuesday, do you have to start complying on Wednesday type of situation? How quickly do you have to do this if the court order changes? So you may want to be prepared for it here. The other kind of counter argument to that, though, is, again, this is part of the ACA. It could eventually go away. It's not part of the AHCA repeal bill. This would still be in effect, but it could eventually go away, maybe, again, later this year, maybe in 2018. The other aspect to it, too, which, again, was not stayed by the Texas court, is some notice language where you have to basically put onto maybe like explanations of benefits or other descriptions, summary plan descriptions, basically saying that you're not going to discriminate against individuals on the basis of race, color, national origin, sex, age, or disability. And the kicker for that one, though, is it's not just in English; it's in about 14 other languages too. So it can really increase the length of like your EOBs if you suddenly have to have 15 different statements attached to them. Federal contractors also have similar rules if you're a federal contractor for some June 2016 regulations, which are out there. All right, disability plans. Disability plans, one kind of quick point to note here, I don't know if we have any church-related entities, Catholic hospitals or Lutheran hospitals or entities like that. Sometimes those entities have taken the position that their benefit plans, retirement, health, welfare, are not subject to ERISA. And if you've taken that position, you should look at it. There's been a lot of litigation in this area, where on the pension side especially, there's been some challenges, and pretty uniformly, the hospitals have been losing in federal courts, and they previously said their plan wasn't subject to ERISA, that there was a church plan exemption available. They've been losing, and therefore ERISA has been found to retroactively apply, which means that they have to do a lot more funding to their defined benefit plan. Same thing was just challenged last month in a disability case. Loyola Marymount out in California, Catholic affiliated university, was sued in state court with regard to their disability plan. They claimed that they were a non-ERISA plan, that they had this church plan exemption, and therefore they could kind of ignore some different rules. Question turned on whether ERISA preempted the state law claims. Court refused to grant Loyola's motion to dismiss. So again, it has been kind of a hot button issue out there. But again, if you're non-church related entity, not too big of a deal. The one piece that is new for disability plans for everybody that's out there, whether you're church plan or non-church plan, final claims procedure rules were issued in December of 2016. Fairly burdensome for employers and disability administrators. So if you administer your own disability plans, or maybe on the long-term disability side, if you hire a third-party carrier to administer your LTD, certainly if that piece is self-funded, you're going to want to talk to the administrator to make sure that they're following these new rules. They're generally effective in 2018, and what they basically do is they take the claims and appeal rules that you're familiar with that were expanded for health plans, and they apply them in the disability context. One other point too, although these came out in December 2016, that means that Congress could, if it wanted to, kind of easily overturn them. There's a rule out there saying that any regulations issued in basically the last 6 months of a presidential administration, that Congress can, by just a simple majority vote, overrule those regulations. What happens is presidents kind of, toward the end of their term, Republicans and Democrats, they stuff in a bunch of new regulations, and some of them are kind of too quickly passed and enacted. So it gives Congress the ability to kind of overrule them. We've not heard any indication that Congress is looking to overrule these disability claims procedures, so I think that they will be in effect starting in 2018. So in terms of what they require, first of all, adverse benefit determinations have to have a discussion of the decision, including the basis for disagreeing with any disability determination by a physician. So, you know, if your claimant or your employee presents a doctor's note saying, yes, he's disabled, if you, as many employers do, reserve the right to make them go to a second doctor of your choosing, and if there's a disagreement, if your doctor says, no, he's not disabled, you have to note kind of that disagreement among the physicians now, and you have to be very clear about why you're kind of believing your physician instead of their physician. If the plan fails to strictly follow these claims procedure rules, the regulations say that if there's a lawsuit, that the court should not defer to your interpretation, that it should be de novo review, a Latin term, which is bad. You don't want de novo review, you want deferential review. Usually if you follow these rules, then it gets challenged in court. Unless you're being arbitrary, unless you're being capricious, the court is going to defer to your interpretation. But here the regulations say if you don't follow these claims procedure rules, the court doesn't give you that same level of deference. A lot easier for you to lose in that situation. There are some exceptions for de minimis errors. You know, you're supposed to send out a notice in 30 days, and you send it out on day 31. Something doesn't harm people, etc. But again, we think that employers here in 2017 are going to look to establish procedures to make sure that you're following these rules, your vendors are following these rules, etc. What else is in there? No conflict of interest in the reviewer. So again, if you are, again, administering your own plans, make sure that the reviewer is not, you know, looking at this and has some baked-in financial bias. Very rare for this to happen, but it actually has happened for one of my clients in the health plan context. The health and welfare benefits manager for a client that I was working with when I was explaining the ACA changes for the group health plan side of things, I mentioned this no conflict of interest rule. And she said, well, just so you know, I get paid a bonus for the more claims that I deny under the health plan. And she was on the appeals committee. I said, really? Yeah. So it does happen. You know, it is out there. So again, you know, look at your procedures. Very rare, but it could actually happen. Notices have to be in a culturally and linguistically appropriate manner if 10% or more of your workforce speaks language other than English. Similar to what we saw in the health plan side of things under the ACA. Prior to the decision on the appeal, claimant has to be able to present new or additional evidence and has to be told if you come up with new or additional evidence as part of the appeal, along with the new rationale for the denial, then they have some opportunity to look at that evidence and kind of challenge it. So again, a little bit of a change in terms of the procedures. You probably should update your SPDs, your plan documents, other things describing this process. The regulation generally became effective January 18th, 2017, but it's effective for plan year starting January 1, 2018 in general for most of these. The only ones which are effective as of January 18th are the two at the bottom here. you have to provide a specific rule, guideline, et cetera, that you relied upon in making an adverse determination, or state that it's available upon request. So again, that is a change. It kind of snuck in there. I think a lot of employers were not paying attention to this because it came out so late near Christmas, et cetera. So do go back and look at your policies and procedures on that. And then if a claim is denied because of medical necessity, experimental treatment, or a similar rule, then you have to provide a notice to that effect. That's kind of your basis for the denial. Other ACA tweaks which are out there we wanted to mention to you. IRS continues to struggle with how to treat opt-out payments. Here's the basic issue. If you have an employee and you say to the employee, hey, we will pay you $100 a month to not take our major medical plan, to go onto like a spouse's plan. $100 a month saves us a lot of money. We're happy to pay it if you go someplace else. The question is that $100 per month taken into account for purposes of determining whether the coverage is affordable? As you probably all know, there's I think a 9.69% is the maximum you can charge for self-only coverage, 9.69% of their W-2 wages. And the question is that in that example, does the $100 count against you and make you go over that 9.69%? The IRS initially signaled that it would count towards determining affordability. Then in IRS notice, I think it was 2015-87, they said, we're still looking at this. Until we get back to you, you don't have to count it against yourself for affordability purposes. In December 2016, the IRS again extended that relief. They said, we're still looking at it. So it's good. Until they give us some further guidance on it, you don't have to count it against you from an affordability perspective. It may be coming at some point and may be an issue, but for now you're okay. Deadline for furnishing the forms 1095B and 1095C to individuals for the individual notice was extended by 30 days from January 31st, 2017 to March 2nd, 2017. That's good. Of course, we're past that, so hopefully you got it out. No changes to the IRS deadline. So paper was due, if you're filing by paper, February 28th, 2017. If you're filing electronically, it's due March 31st. So again, the IRS forms, you still have a little bit of time, March 31st, if you're filing them electronically. You can always get a 30-day extension. It's automatic as long as you file Form 8809. We did have a question recently about what if you have to file 250 or more with the IRS, but you want to do it on paper. The IRS rule is you're supposed to file, if you have 250 or more forms to file, you're supposed to do it all electronically. In case you're curious, you really can't do it by paper. They take the position that if you file like 300 forms by paper, they take the position you haven't filed anything. They just apparently throw them out and can hit you with penalties for that. So be careful. If you're supposed to do it electronically, do that. Good faith penalty was renewed for 2016 related filings. The IRS had previously said that if you're trying in good faith to comply with these rules and you mess something up, your software is messed up, something like that, as long as you're working in good faith, they won't hit you with penalties for filing errors. Other sort of ACA tweaks, OSHA. There's kind of a strange regulation under the ACA saying that employers can't retaliate against employees for obtaining exchange subsidies. So you can't penalize employees who go out to the exchange and get subsidized exchange coverage. There's new OSHA regulations from October of last year which clarify what exactly you have to do. In general, they're good for employers. There's no notice that needs to be posted. It's just a rule, so you don't really have to tell employees in terms of like a public posting, so that's good. Employees have to file within 180 days of the alleged violation. That's good. Again, kind of setting a quick time period for employees to file a complaint with OSHA. There's one clarification which is kind of anti-employer. It clarifies that an employee receives a tax credit if they're merely eligible for the subsidy, even if they don't get it. So, if an employee says to you, I'm going to go get this exchange coverage, I'm going to get a subsidy, you fire them for doing that, even if they didn't actually get it, just them talking about getting it will be sufficient. Other kind of ACA tweaks, I asked this one before, will we ever see any pay-or-play rule, employer shared responsibility rule penalties? No one in the room raised their hand in terms of receiving penalties. I haven't seen any, so I kind of think we won't really ever see penalties, which is interesting. Under the Obama administration at the very end, the IRS had hinted that they were soon to be sending out notices of penalties. but we just haven't seen anything yet. Or maybe all my clients are good clients. I don't know, who follow the law. That could be it. That must be it. So we'll see where that goes. Other little kind of FAQs which are out there. There was kind of a couple important ones. One from April of last year, one from October. They're dealing with all these little different issues under the Affordable Care Act and mental health parity. You should look at them. Probably more of an issue for your TPA or insurance company, to be honest. Like, bowel preparation medications. Are those considered preventative care for purposes of receiving a colonoscopy, which is definitely preventative care? And they came out that yes, the little things you have to drink before your colonoscopy is part of the process. Plans have to pay for it. Again, employers usually don't get too involved in the details like that. Kind of rely upon your TPAs to do that. Same thing with tobacco cessation. Some October FAQ said, hey, what exactly has to be covered for tobacco cessation, which products, in what quantities, how often do people have to have it available to them? Again, that's out there. And again, more of a TPA issue, but we're going to flag it with you. New SBCs. This is more of an employer issue. So in April of last year, they came out with a new summary of benefits and coverage, and this has not gotten much attention among the employer community. This rule, this new SBC, does start applying for the first plan years beginning on or after April 1, 2017. So if you're an April 1 plan year, this is the SBC you're supposed to be using. Don't use the old SBC template. The new one has new coverage examples. It has different questions on it. The structure is a little bit different. The glossary of terms have slightly changed. So this is the one you want to be using here. We did have a client say, can I give you my old 2014 SBC and can you just update it? I gave up on it because there were too many little changes throughout it. So maybe I shouldn't have. It really helped my billable hours. But yeah, I told him no. If you're just start with a new one, and that'll be a lot better. So again, some point this year, maybe as soon as next week, if you're an April 1 renewal, you got to worry about this new SBC. Mental health parity. Just a couple quick points on this. Again, we've talked at Alliance things before about mental health parity and how it kind of requires super parity between mental health and rental health and substance abuse disorder benefits be treated, I think, arguably better than medical surgical benefits. A couple quick updates here. 21st Century Cures Act, the December law, again, bipartisan support from Republicans and Democrats, directs for these rules to be strengthened. They basically think that employers are not following these rules. Republicans and Democrats, bipartisan support, want employers to be following these rules more strictly. Directs HHS, DOL, IRS to issue more guidance in this area with more examples. That has to be finished by December this year. So we will see further mental health parity guidance later this year. It has to be updated every 2 years. So we're going to keep getting refreshed guidance in this area. Action plan to coordinate federal and state enforcement. Mandatory audits of you if they find 5 or more violations. This is the only mandatory audit provision that I'm aware of in the benefits world. So if you have 5 or more violations, they will send somebody out to your office to do an audit for parity compliance here. Very interesting. Agencies have to report to Congress every year on serious violations. Congress wants to know what's going on. And then the GAO, the Government Accountability Office, audits HHS, DOL, and IRS to make sure that they are following the enforcement rules. So not only do they want more enforcement, they want the enforcer of the enforcers to verify that the enforcers are doing their job. So again, very, very strong rules here. Clarification on eating disorders. The plan covers eating disorder benefits, including residential treatment. Plan must make sure it follows MAPIA, mental health parity. Some plans that eating disorder benefits are not covered, but that's not really something to cover. This very clearly says that you have to cover it. Seems to have been immediately effective. The day that President Obama signed this into law, December 22nd or whatever it was. No grace period for employers, so you should look at that and verify you're following those rules. There's also some new FAQs from October 2016 that I mentioned before. Other quick MAPIA things, 191 plans were reviewed last year for MAPIA compliance, 44 cited for violations. That's across the country, so it's not huge yet, but again, the agencies are getting pressure to do this. Typical penalties, unfair penalties, prior authorization more stringent, inequitable residential treatment exclusions. So it's easier to get medical surgical covered at a skilled nursing facility, but on the mental health side, maybe clients don't want to pay for mental health services at some of these residential facilities. And I do have a little bullet point. Are mental health providers abusing this rule? And maybe by show of hands, I'm curious, how many of you have seen, because I've been in Madison and seen this commercial, commercials for, it's like a guy in a blue coat saying, do you have mental health issues or substance abuse issues? If so, call this number and your health plan has to cover it now. Anyone seen that commercial? Wow, okay, so let the record show. It was about half the people here, so a fair number of people. What that is there's a whole new industry springing up of brokers who basically trying to find people with these illnesses. Then they turn around and convince the people to go to spa-like resorts, is how my clients are phrasing it, usually in California or Florida on the beach, and they charge, I don't know, $10,000 a day or something like that, and they insist that you be there for 2 weeks. They do drug testing 3 times a day. They send it to their own lab that they own. Every time they test, it's about $2,000 a test. Even though if they had sent it to a little Milwaukee clinic, it'd be $20 because they're sending it to their clinic. It's $2,000. Anyways, we've had a ton of clients who have identified this trend and are trying to crack down on this. These clinics are rolling in the dough. They will actually fly your employees to go down to the spa-like clinics because they make so much more off of you in the back end with all these testings that they do. So they will fly employees to Florida, to California, sit on the beach, and recuperate from their mental health issues and the big bills. We've seen $200,000, $300,000 bills for these treatments. So you may want to talk to TPAs about that. Again, maybe our experience is unique, but we've seen a fair number of clients be very concerned about this. So that's why I say our mental health providers kind of abusing this rule. Again, there are other kind of typical MPA problems out there. Wellness plans, a couple of quick points here on wellness plans. Final regulations issued from mid-2016. If you haven't reviewed your plan documents, you should. Still kind of a disconnect between the HIPAA wellness rules and the ADA wellness rules. Again, the ADA ones are a little bit more stringent. These rules will take effect. AARP had sued on behalf of employees to try to prevent these rules from kicking in. Effective 1/1/2017, they felt that they were too pro-employer, and AARP lost. And so these will go forward. EEOC versus Flambeau. Flambeau, obviously a fine, upstanding Wisconsin company here, so kind of an interesting issue. EEOC had sued because the employee had lost coverage for failing to timely complete a health risk assessment. Employer has a good defense, the bona fide benefit plan safe harbor defense. Lower court agrees with the employer in this case, but the EEOC continues to fight it. The employee continued to be upset about it. So it went to the Seventh Circuit. Seventh Circuit kind of just kicked it away. They said the employee is no longer even employed there. This is an old issue. The employer reversed its decision, allowed the employee to get back on. It's moot. And so they wouldn't really decide it. But it continues to be kind of a lingering issue of, again, the EEOC taking the position that this one safe harbor, which is their own regulation, by the way, they just won't ever change it, that their own regulation doesn't, in fact, apply. There's kind of an ongoing dispute with that still. Form 5500 changes, just a quick point on this. This is a couple years down the road. Large set of regulations proposed last year relating to 2019 plan year. There's potentially some new filing information which is going to have to be sent out. Comment period was extended until December of 2016. We created a new Schedule J where you'd have to be putting a lot more information into your Form 5500. Type of benefits offered, what the contribution level is, your contribution versus employee contribution, COBRA questions, different questions about your insurance company, grandfathered or not. The one thing which to me is probably the worst one up here is the last bullet point, answer questions on compliance with various laws. So basically if you had an error involving some of these laws, MPIA, HIPAA, et cetera, COBRA, you now would have to tell every year the federal government, yeah, we had an issue with HIPAA. Now, why am I concerned about that? Because you're kind of confessing your sins, right? Right now, if you have a HIPAA problem, you call your benefits lawyer, you fix it, you move on, and unless you're audited or unless the employee complains, it never really sees the light of day. This would make it very easy for the regulators to give you a quick phone call and say, hey, I see you had a HIPAA problem last year. Did you pay a penalty? Did you fix it? Explain to me what the issue is. So that to me is kind of the worst piece of these proposed regs. Again, this is a 2019, may never come into fruition, may get sidetracked here, but we'll see where it goes.
Right, thank you. Thanks to everyone for being here today. Let's give John a round of applause.
Thank you.